Black women have the shortest survival rate and highest death rates of any other group in the United States when it comes to most cancers. To discuss the roots and realities of this troubling healthcare disparity, we are joined by First Coast News anchor Keitha Nelson. Good morning,
Hey,
Keitha.
Ann.
We're also joined by Dr. Kelli Tice, Chief Health Equity Officer and Vice President of Medical Affairs at Florida Blue. Good morning, Dr. Tice.
Good morning, Ann. Thanks for having me.
Thank you for being here. Keitha, the statistics are stark. As you've reported, Black women are dying of cancer more than anyone else in this country. But you approach this story not just about the statistics, but about the stories. Tell us a little bit about some of the people that you met.
You know well, that's what it's all about. It's the people, and that's what kept me going through all of this. I started out by reading about the study underway by the American Cancer Society. So what they're aiming to do is do a research study involving 100,000 Black women across 20 states, including Florida and Georgia, over 30 years. They plan on studying these women to find out exactly why it is that Black women, in particular, are dying of at this disproportionate rate of cancers compared to all other races and ethnicities. And when I read that, I was kind of like, what is going on exactly? So I ended up all the way in Atlanta speaking with the lead researchers of this study. And the more we spoke and things came in the open, I was just mind blown. For one, there's conversations that we have amongst each other, in small groups, such as people would say things jokingly like they're trying to kill us. But when you hear things such as hair care products, or different lotions, things that are marketed towards Black women, possibly being connected with cancer and being connected with our health issues. It's kind of like, red flag, hello. And so that's what this research study is aiming to do, is to look deeper into these things that we've spoken about for generations, to figure out, is this true? Is this in fact leading to our demise? And throughout this study, because we started back in October of last year, we're still going strong, still going to do more of these series. But throughout this, I found out that it's way more than just products that's leading to this. There's also disparities within healthcare. That is a huge one, and I'm so glad Dr. Tice is here today to really shed some light on that. Because the more I spoke to her and others, I was just mind blown.
Yeah. And one of the people that you met in this, the series of stories that you did, and then ultimately the special that you put together is Von Seal Bradford. She's from West Jacksonville. She's a very young cancer patient. Tell us a little bit about what she encountered when she first noticed something amiss with her breast.
Von Seal's story is way too familiar when you speak to Black women in particular. Is that she said, "I was trying to get someone to listen to me, but no one was listening." Now, she was rather young, in her early 20s, when she found the lump in her breast, and that too sometimes has a lot to do with it because of restrictions or regulations. People assume that because of your age, you likely do not have breast cancer. But the more, and you'll find out in this series if you get a chance to watch it, you'll see that it's really all about breaking down those barriers, speaking up for yourself. You know something is wrong, even though the medical professionals are telling you, no, no, it's likely not that. It's just this. She advocated for herself again and again. She even recalled a time when she was in the hospital, not in the hospital, but in a medical examining room, and she's telling them something is wrong, and they're dismissing her. And she got furious, irate. They say the term angry Black woman. She became that angry Black woman. But that's what it took to save her life. And again, her story is way too familiar. I've heard it time and time again. Jessica Florence, another one. Jessica, though, unfortunately ended up losing her life. But well, again, more of this is to come within the series if you look at it. But it's just way too familiar. These stories that you hear about people saying we are not being heard. Our stories.
This Dr. Tice is not unique, as Keitha says, and the need for women to advocate for themselves, particularly Black women, when it comes to issues like this, is not to be underestimated. But tell us a little bit about the statistical side of this story when it comes to the disparity that is seen among Black women in different kinds of cancers.
So, I appreciate the opportunity to highlight this, right? We can't get to solution without understanding the data. Like, what really is the problem, right? And I think that the thing that is the most stark statistic for me is that the breast cancer isn't more common in Black women,
right? We talked about the things that can increase the risk of developing breast cancer, some things that are marketed to Black women. But breast cancer is actually not more common in Black women, but Black women are 41% more likely to die from it. That is the end of the story as far as I'm concerned, because that what that means is there are multiple things that are going on that are causing Black women to not have the same opportunity to have a successful outcome. And that's what has to be addressed. It is probably the worst example of how disparities show up in disease. Now, other cancers across the board, lung cancer, colon cancer, all of the most common types of cancer have higher death rates for people of color and, in particular, Black women of color. Some of it is driven by the fact that it, we have clinical barriers that exist, right? So, screening guidelines are set up based on norms, averages, for example.
Explain just what is a clinical barrier as opposed to something you just encountered in a doctor's office?
So, for instance, your insurance will only pay for screening tests if you're of a certain age or are deemed to be at higher risk. And a lot of those risk factors come about, they're familial. For instance, if a cancer runs in your family, or if you're of a certain age or a certain ethnic background, it, people of color, Black women in particular, have been historically underrepresented in all of those studies, right? And so if you're not in the data set from which the actual guidelines are created, then there's no opportunity for you to then have the guidelines shaped toward you.
Gotcha, and so if you are presenting as a Black woman and there aren't a lot of people in a study that was used to develop, for instance, whether Medicaid pays for early screening or breast cancer detection, it's less likely that you'll be able to obtain that service.
Exactly. So, and most payers, Medicaid and commercial payers, actually use a standard set of guidelines to build their to frame their programs in terms of what they will pay for. Um, and there is an organization called the United States Preventive Services Task Force, where we as physicians are sort of trained to look. And what that organization does is look at the evidence across the board and make recommendations based on a lot of data. So, that's how we get um, cancer screening age sort of uh, guidelines established. So, certainly by the age 45, you need to have had, at least a baseline mammogram, whether it's recommended annually or every other year based on your history. All of that comes from the USPSTF, the U.S. Preventive Services Task Force. And so all of the sort of decision makers look to that particular organization to sort of set their standards. But again, the question we don't ask ourselves is, what is the representation that is utilized to determine those guidelines that we're all pointing to? And the problem is, when there is a change and when there is an impact to an underrepresented group, guidelines like that are pretty slow to change. Um, Prostate cancer is a great example of that, right? It is more prevalent in African American men, and the screening needs to begin at a younger age for Black men than for others. But it took a number of years before the guidelines sort of changed. And I think studies like this one, the Voices study, will begin to shed light on some of the things that may increase risk, and perhaps as a result, we hope, influence the guidelines that then will cause insurance companies and others to align in terms of ensuring access to the appropriate screening at the appropriate time.
And to bring that to a human example, this person, this woman that Keitha interviewed, Von Seal, I mean, she had a noticeable lump in her breast. She had a discharge, which,
Mhm.
I think in an older woman would be an instant red
Mm.
flag. But her age and also the fact that she was receiving, I think it was
Medicaid at the time, she
m-
wasn't uh,
eligible.
some of us have, insurance that would cover those type of things. Not all of them do, or they cover them at different extents, and she believes she was treated differently because of that, because of the type of insurance that she has, and again, her age. And if you speak with Von Seal, she'll tell you her race had a lot to do with it as well.
And so, what does it mean, Dr. Tice, when you are getting a late diagnosis in terms of successful outcomes of any kind of cancer treatment?
Well, I think it's really important that we talk about the risk that is that younger women face when having a diagnosis of breast cancer. Those cancers, by definition, actually tend to be more aggressive.
Mm.
And I think that in Von Seal's case, for instance, the fact that it took so long for her to have the first diagnostic test is of great concern. Anyone involved in the care, no matter the payer, Medicaid or any other insurance, the clinical response to the symptoms that she described would have been a simple imaging study. Perhaps we're not doing a mammogram first, but an ultrasound could have been done very early on to determine whether you were talking about a solid mass, which is much more worrisome for cancer, or something that's cystic or fluid filled, which is more common. Um, and then you sort of go from there. But in my opinion, it becomes very difficult to reassure based on your lived experience as a clinician, your your um, your assumptions based on the patient's age or presentation, without the basic diagnostic test that says worrisome, not worrisome. So I think that was a big miss.
Mhm.
This is, as you said, this is not just breast cancer. This is cancers of all kind. And I think that one thing that has become more apparent in recent years is this is not something that is confined to people of a lower socioeconomic status or who might be marginalized in other ways because of education or life experience. That this is something that women of all professional levels and incomes experience in a similar fashion. Um, Physicians have written about it, and I wonder. I mean, has your own experience been? Um, has it reflected that in your own professional life?
So that's a very important question, and I think that's what we have to deal with, right? Much of what we see in health disparities. So in disparities, what it means is we see a higher burden of illness or disease or poor outcomes in certain groups in comparison to others. Disparities are driven not by genetic differences, right? Disparities are driven by, the things you described, access and those sorts of things, but also very strongly influenced by bias. And in the cases that we've discussed thus far, we know that that was actually at play. That perception that women of color in particular have, that their complaints are being dismissed, that their reports of pain are being ignored.
Mhm.
2017, there was a study that came out that actually indicated that residents in training still believed the idea that pain was actually perceived differently based on race. They thought Black folks actually experienced pain at a lower rate than others. 2017,
Yeah.
okay? And I'm talking about
And these are the
physicians in
future doctors of America at that
Correct,
time.
correct. And so the bias shows up and it influences how you are treated. It also can be really discouraging to have your symptoms dismissed and make it difficult for you to advocate for yourself. And I wanted to circle back to that because I think that's really important. You opened with, the value of advocacy, self-advocacy. But in groups that have been routinely sort of disenfranchised, ignored, not had access, not been treated well when they have had access, advocacy can be very difficult.
Mhm.
And, I started my career working in a federally qualified health center, and I had patient after patient who would say to me, "Hey, can you space out my visits a bit? Because it's really hard. The lady at the front desk is just, they're so rude to me." Or, I just, when you send me to see the specialist, like, can you call them beforehand? Because last time I went, they didn't listen to me at all. Those sorts of things. That shouldn't be, right? But that's bias. That's the clinical staff perhaps being sensitive to a lower reimbursement rate that they may get with certain insurances, right? It may be that they have developed a bias because folks without access tend to be late to appointments. They tend to miss appointments or have to reschedule them at the last minute because they have transportation challenges or don't have the copay or all of those things, right? And so it is our responsibility to contribute to the building of a health system that opens its doors widely to everyone and creates the same level of comfort that you would suspect I would have if as I seek care as others.
But do
Mhm.
you feel like you experience healthcare that is different from what you're describing your patients experience, or do you experience something similar?
It is similar in a lot of ways. It's probably similar in too many ways.
Mhm.
I think, once we are placed in the gown that ties in the back, right? Um, the the feeling of sort of privilege that comes with education or executive status or that sort of thing goes right out of the window. And certainly, yeah, I've had 4 children. and all the care that I've had related to those deliveries, I did experience, that same feeling of having to sort of really advocate for myself because I was clear that I wasn't being seen by those that were delivering the care. And I think that's the difference that we can't discount as we talk about self-advocacy.
If you're just joining us, we are talking to First Coast News anchor Keitha Nelson and Dr. Kelli Tice about racial disparities impacting the health of Black women. If you'd like to join our conversation, you can give us a call at 904-549-2937. You can also email First Coast Connect at wjct.org, or you can reach out on social media. In terms of the experience that women have, we actually did a segment in May on disparities in healthcare. And we talked actually to one of our colleagues, Henny Smith, Keitha,
Mhm.
talking about her experience when she went to the clinic as a teenager. And she described overhearing the doctor outside her room saying, she can just wait. She's a morbid, obese Black woman. She can just wait. And this is what she had to say about how that experience impacted her.
I was very hesitant in going to the doctor and I will say, in all fairness, it's still kind of that way to this day. I have to be in a lot of pain to go, and I know that it came from that experience. I can tell you what I had on that day. Like, that day is so vivid to me because it hurt, and it just stuck to me because I could not believe that a trained medical professional said those words out of his mouth about a patient and said it loud enough for me to hear it.
Yeah.
Keith, I said Henny Smith. I meant Henny Stewart, of course.
Mhm.
But this kind of experience, it is still painful for her.
Yeah.
And it's really extraordinary to hear how it attaches to even the healthcare that she seeks today, saying that she has to be in a lot of pain before she'll go.
Yeah. Uh, Hearing Henny, hearing Dr. Tice, it made me think back to a conversation I had with one of the lead researchers of the Voices study, Lauren McCullough, about systemic racism, racism within the healthcare system itself, because she herself, a very accomplished researcher, scientist, she has I don't know how many degrees at this point. She herself said while having her second child she experienced racism, and that too made her feel like, if I'm experiencing this, I who am, clearly have the right insurance, right? Have the funds needed to get the medical care that everyone deserves. If I'm being treated like this, how are our sisters that are not in this position, not of this educational level or background, how are they being treated? So hearing what Henny said, no surprise. No surprise there. It's the sad truth. And that is why this study, Voices of Black Women, voices.cancer.org. I can't say that enough. That is why this study is so important. It's so important that you log on to voices.cancer.org to see if you are eligible to be a part of this study, because you heard Dr. Tice say it. If we are not a part of these research studies, we won't find out what is leading to the disproportionate amount of death rates that we're seeing amongst Black women in particular. We have to find out. We have to be a part of the solution. Enough complaining, let's be a part of the solution.
We've got a call from Stanley on the north side. Good morning, Stanley. Go ahead.
Happy New Year's, everyone. I run the African American Economic Recovery think tank, and one of our pillars is preventive health. Every time I talk to African Americans, especially in leadership, they're not concerned about preventive health. And my concern here, when it uh, when it comes to the health care, not the health care products, when did that change take place? I'm talking about the time period between the hair care products and natural hair. Thank you.
So that's a good question. I mean, the FDA has actually, recommended that the products in some hair relaxers not be sold anymore, that they're that much of a hazard. And yet that those products continue to be sold. That ban recommended by FDA has not been implemented.
Yeah. So I'm glad you brought that up because I did reach out to the FDA for this study. So the ban was supposedly implemented in April of last year, and the response I received was I'm laughing because it's ridiculous. They're saying that it's difficult. It takes time to put these bans in place. If you have people losing their lives, if we're not sure if this is leading to death, maybe we should just, hold off a little bit, do some more research, and then possibly make it available later on. But the fact that it appears that they're being lax about this, it hurts a little bit because then you wonder if this was affecting a different group of people, would that ban have been put in place? Would there have been more emphasis put on this? Would it be more important? It just brings up these questions.
I mean,
It's not known.
there was a study this year by the National Academies of Sciences, Engineering, and Medicine, and they actually were very stark in their findings. Dr. Tice said the U.S. healthcare system is, quote, by its design, delivering different outcomes for different populations by its design, saying that there's been in the past 2 decades almost no progress in eliminating racial disparities in healthcare, even though there's been promises to make that change. And they found that many times the well-being of Black people are, quote, at the mercy of powerful business and political interests, which I would imagine removing products from the market would fall into that category of something that is difficult because it's going to cost money
Mm.
and run afoul of people's, you know, financial interests.
Absolutely. And it's unfortunate that we're even here having to have such a discussion. But this 20 years ago, the unequal treatment, was published, and it actually um, talked about what you just described, right, and set these goals for the healthcare system to begin to work on health disparities. And 20 years later, many of us who, I was just had really just begun my career at that point. 20 years later, finding that there had been significant improvement is of concern. But here's the key: the system produces what it is designed to produce, and we created a sick care system that was really designed to function on the payment for services delivered to folks who were sick. And so, to the caller's point, there was not any significant investment in preventive health, right? And in order to do that, you have to think outside of your screening. It has to do with your environment. What do you have access? Do you have access to the things that are required to be healthy? Do you have information that helps you to understand? Absent an FDA ban, do you have an understanding of what is in the things that are being applied to your body, the hair chemicals and other products that are in use? There is a disparity of information delivery to populations that are underserved that actually perpetuate this, just like there is a disparity in the delivery of nutritious food and clean air and all of the things, right? And so it's so complicated that I think as we have leaned in to try to solve this, because we have done so in a piecemeal fashion, we may make progress in one area, like access. There are a lot of chief health equity officers that now exist across the country and, in various areas of healthcare and in medicine. But we haven't made a great deal of progress in creating healthy environments in which folks live. We haven't made great progress in the delivery of actionable information to the folks who need to use it to apply to their lives. And we talked briefly about bias and racism. And when I heard the soundbite from Honey, obesity itself is a source of extreme bias that exists in the healthcare system, and it is very common for folks who have obesity to be dismissed, have their symptoms not worked up at all, because it can all be attributed to their weight. And so if you add Black, female, obese into the mix, then the likelihood that your symptoms would not be well addressed it becomes much more likely. And then it impacts, of course, her behaviors, right? It's such a complicated thing that our conversation today and the Voices study, and I think the level of awareness that we're hoping to create with these conversations really should drive change across the healthcare continuum.
This study, Keitha, is a longitudinal study. It's
Mhm.
women who don't have cancer,
Right.
right?
Mhm.
Who are, I think, under 55.
Yeah, 25 to 55 is believe the range that they're
But
looking
this is
for.
going to go for 30
30
years.
years, yeah, yeah.
So it's
It but when you think about that, I mean, 100,000 Black women, 20 states, 30 years. When you think about the information they'll be able to gather, finally, some solid info, some solid research that can be applied to all of these issues we're seeing across the board when it comes to healthcare. That makes you a little excited and hopeful for the future generations.
well, I want to ask you about that because you're urging participation, and yet there is this terrible history of
Mhm.
Black
Yeah.
women in the system being uh, abused,
Mhm.
exploited. Even as you've reported, the father of gynecology.
Marion Sims, yeah,
uh,
yeah.
I mean, abused terribly
Yeah.
female Black patients that were enslaved.
We had a chance to sit down with the professor at Flagler College, Michael Butler, who went into the deep, dark history of the abuse of Black women's bodies. And obviously, this goes all the way back to enslavement. And with Marion Sims in particular, he spoke about one case that really kind of stuck with me, a 13-year-old woman, a child, who he tried to lease her from the person who owned her, and because of the level of the abuse that was going to be done to her body, the owner said, "No, I'm not gonna lease her to you." So he instead paid for her. He purchased that 13-year-old woman, and for we don't know how many years, did experiments on her
Was without anesthesia.
without anesthesia, and it wasn't just her. So many women, and it's documented. And this is it's a painful history, but it needs to be discussed so that we understand why we are where we are today. Because this also leads to what Dr. Tice mentioned earlier back in 2017, you not knowing why it was that we believe that Black women experience a different level of pain. This goes all the way back to enslavement. That's the mindset, is that we can handle it.
Mhm.
These are children that were experimented on that experienced this pain, and so the bias continues. How many, decades later, generations later, to still believe that we are able to handle pain better than others, and
Okay.
it's false.
And there is also Dr. Tice. I mean, we were talking before the program about the legacy of Henrietta Lacks, who,
Yeah.
went in for a cancer treatment and instead, had her cells harvested for experimentation. Certainly the Tuskegee experiment, another case in which men were not treated for existing disease. So, what do you tell people when you're encouraging them to participate in something like the Voices study, to say, now is the time to be, a part of this study? What's changed?
Can I just say this really quickly? Let's make it clear. This Voices of Black Women study is a research study. Everyone out there who are telling to go to voices.cancer.org, this is not a clinical trial. It's a
Meaning there's
research
no,
study where they're not drawing blood.
Observational. It's
Yeah,
observational.
observational. This is
they
they're
don't have
not
to
drawing
take any
blood.
medicine.
No, I'm a part of it myself. I'm speaking firsthand. I signed up for it. Dr. Tice did as well. They're asking you a series of questions over the next 30 years. That's it.
Okay.
You can save lives by simply answering questions. This is not a clinical study.
But still, there is that faith that needs to be established or
Hmm.
restored.
Oh, absolutely. I sit at a lot of tables where we talk about health equity and the work that needs to happen across the country. And one of the things that we've said more than once is that the industry has earned the mistrust
Mm.
of minorities in this country, and so we have to earn the trust again. And in doing so, I think um, we have to do the things that I described. We have to communicate openly and appropriately about the expectations. We have to be clearer about what the value is of participating in things like this. And while it is an observational study, there is an opportunity, if you consent, to have blood drawn, to have certain markers sort of evaluated and that sort of thing. And I in fact got my box. I might be older than you, Keitha. Maybe that's why I qualified for that. Just saying. But I got my box in the mail, a couple of weeks ago, and now have to schedule time to go and have my labs drawn. And it gives you pause as you think about that. And I wanted to be certain that we declare that, right? That it may be uncomfortable at all of the stages. When you fill out the lengthy application, when you now then are asked perhaps to go and submit a sample of blood. Um, but we have to remember the investment. And the things that clinicians who are trusted in the community and leaders like you, Keitha, who are shedding light on these stories, I think the thing we have to be able to do is say, here's why I'm participating, right? And as when I was in patient care, that's how I talk to my patients' parents and about their own care. If it were my loved one, here's what my approach would be. This is my opportunity. I wasn't at the table before, but I'm at the table now, and I have this opportunity to contribute to the legacy of knowledge that exists for people who look like me. And yes, it's a little disconcerting that, I've got to go to the lab and have this blood drawn, but I see it as an investment because there are folks who didn't get to be at
Mm.
this table.
Yeah, and I just want to kind of return to the people, Keitha, because we talked about Von Seal. She told you that she was in a text chat group with two other women who were diagnosed with cancer, and the chat group was called the Sisters That Will Survive. One of them was Jessica Florence, who had an 8-year battle with cancer. Um, the other woman, Stephanie.
Yeah,
Both of them died.
both of them died. And Von Seal is still here. I remember asking her that question, and her pause kind of like sucked the air out of the room because I was afraid to hear the response. She was the only one who made it. When it comes to Jessica Florence, her story kind of kept me going throughout this entire thing. She had passed away when we started doing the story, but she documented her entire journey on social media, and I felt like I got to know her because I went through so many different videos and reels from her. But Jessica, something she said time and time again within these videos is that no one is listening to me. That's what this woman said. She knew something was wrong. She continued to advocate for herself, to speak to the different doctors, but she felt as if no one was listening. And when she was finally heard, it was too late.
Well, it is not too late for people to participate in this study. Keitha, just one more time, tell us how people can get involved.
Voices.cancer.org. Simply go to the site and see if you are eligible to be a part of this research study. Some, as you just heard there, you may be asked to draw blood, but you don't have to do that. Some parts are just simply research. That's what I'm involved in. Just asking you a series of questions throughout the next 30 years. Again, even if you can't save yourself, you are going to save possibly the lives of future generations of Black women. And that alone should drive us all to this site to try to help out however we can. Because it's not just about blaming the system and others. What are you going to do? How are you going to be involved in this fight to save the lives of future generations of Black women?
Well, Keitha Nelson's special is called The Untold Truth. We have a link to the full entire half-hour special on our website. Dr. Kelli Tice, Keitha Nelson, thank you so much for being on today. Really appreciate it.
Yeah, thanks
Thank
for
you.
having us.
All right.